In this case, male in his 70s came to the clinic complaining of right lower extremity claudication. I looked at the images and the ultrasound exams, and I decided to perform an angiogram. His lesion was in his right common femoral artery, which is an area that you want to proceed with a little bit of caution because that's the area that surgeons would use for a bypass. So in this case, I decided to do an angiogram and decide during the case whether I would intervene or not. And I used my normal algorithm, which is a contralateral common femoral artery approach, go up and over. And once I was up and over, I performed the angiogram and I saw a short segment CTO in the region of the common femoral artery. So my algorithm is usually a vert catheter with an LLT to try to interrogate the proximal cap to see how easily the wire would cross. In this case, I was able to interrogate the proximal cap, and I was able to get through the occlusion. Once I got through the occlusion, I used a HawkOne LX device, followed by angioplasty with amazing results. The patient was able to avoid a bypass, and symptoms were relieved as well. So I think it's a perfect example of how atherectomy can be used even in areas where I initially didn't feel comfortable with, but over time I was.